while we're getting set up, the first Periodic Paralysis Association, I don't even know if it was called the Periodic Paralysis Association, was 2001 in Niagara Falls. I think it was about 15 of us in the basement of like a Motel 6 or something. And so it's really come a long way. And I've learned so much about periodic paralysis by interacting with you, much more than I have in any medical textbook or journal. So I really appreciate you sharing your stories, because it's truly a two-way street here. So once this gets fired up, what I want to share with you is some of the recent developments in our laboratory, but in particularly that are directed towards next generation of therapies and things in the pipeline. And here we go. All right, terrific. So let me begin by thinking about the journey from the patient to being able to do science and understand more about periodic paralysis and have new opportunities for intervention. So of course it starts with the patient on the left. Sorry, I don't mean to insult anyone with the drooping patient over there, but I was just trying to convey the problems with mobility, and which leads in some cases to the identification of a specific mutation on the gene. And I became involved in this story about 35 years ago, and the first thing we did was try to figure out whether these genetic changes, let's see if I can get a mouse over there. Whether these genetic changes affecting the gene coding for an ion channel really caused the channel to function in a different way. I mean, was this just random chance, or was the channel somehow misbehaving and leading to the problems that you all face with contractility? So the way to do that is to recreate the piece of DNA in the laboratory, get a cell to take it up, it'll make the channel for you, and with some sophisticated equipment, you can record what's going on and characterize the behavior of the channel. The other approach, which is much more involved and happens much less frequently, is to genetically engineer a mouse to have the same mutation that an individual has with periodic paralysis. The beauty there is you can study the function of the muscle itself. So this has been essential for understanding how disruptions of channel behavior interfere with normal excitability and contraction of muscle, and it is absolutely the best system in which to explore preclinical studies on opportunities for new interventions. So lightly outlined there, it's not showing up very well, is to highlight for you, these are the pieces that our lab has personally been involved with. So other colleagues, neurologists have identified the families, molecular geneticists were the first ones to find these mutations, and then we took the story forward from that point. What can you learn knowing what these genetic differences are, and can it explain the basis of the disease, and can you do anything about it? So before talking about the types of defects and what we can do about it, I wanted to just lay out for you the fact that there are many different clinical disorders that are all caused by defects of excitability of ion channels in skeletal muscle. So on the left-hand side of your slide are inherited conditions that cause involuntary aftercontraction or stiffness that neurologists refer to as myotonia. And on the right-hand side of this spectrum are disorders with recurrent episodes of profound weakness, so periodic paralysis. And amazingly, there's some individuals in the middle where the very same person may alternate between episodes of involuntary aftercontraction, which is anomalous hyperexcitability of the muscle, only to alternate with intermittent failure of contraction in periodic paralysis. So of course, that's where paramyotonia congenita and hyperkalemic periodic paralysis live. So we now know, over the last 25 years or so, that every single one of these conditions is caused by a genetic variation or mutation in an ion channel gene. And these are the names of the channel or the genes that you see on the bottom row that you might have gotten back on genetic test reports. And except for these potassium channel genes, which are expressed not only in skeletal muscle, but also in heart and bone, so in that case, when the channel isn't defective, more than one tissue will be affected. So these individuals are susceptible to arrhythmia, long QT syndromes, and the changes in bone that cause characteristic features. But in every other case, the affected channel is expressed and present only in skeletal muscle. So the symptoms are limited to skeletal muscle and not nerve or heart. Whoops, sorry, I'm going the wrong direction. And it can, at first was a little bit confusing. How is it that mutation of a single ion channel gene can cause all these different clinical phenotypes, where people have primarily stiffness or a combination of stiffness and weakness, or weakness but never stiffness, sometimes aggravated by high potassium, sometimes aggravated by low potassium. Where does this all come from? So from studying the individual ion channels identified, the channel mutations identified in patients, we now know, for example, that all these mutations cause the sodium channel to be open more than it should be and let in too much sodium. So those are gain of function changes for the channel. Whereas other mutations in the very same channel cause a defect where there's a leak, not through the normal pathway that the sodium should come into the cell, but in this accessory leak in the part of the channel that makes it sensitive to membrane potential. So very different functional defects in the channel, different biological consequences of that, causing either hyperkalemic or hypokalemic periodic paralysis. So I just want to give you a sense for the flavor where we started out understanding going right from a specific DNA mutation to what's wrong with the channel to what type of periodic paralysis are you going to have. The next step is that we made genetically engineered mice. So we have 3 different mouse lines that we've been studying for many years. One that recapitulates hyperkalemic periodic paralysis, and 2 for hypokalemic periodic paralysis, one from a sodium channel mutation and one from a calcium channel mutation. And to show you the high fidelity, robust models that are created by this, I'll show you the type of data that we have and how it demonstrates the susceptibility to paralysis. Because as many of you know, there's a lot of biomedical research with terrific intentions that tries to create animal models so that we can ask tough questions and try to make progress. And a lot of times the animal model doesn't quite match the situation in the humans. But in this case, it's a fantastic match. So in this mouse, we've introduced in the calcium channel this R528H, arginine at position 528H to histidine. This is the most common mutation in periodic paralysis, and it's called hypo-PP. So the mouse looks fine, it runs around the cage, it eats, it breeds, it makes more mice, great. And so what we needed to do was look for susceptibility to attacks of hypo-PP. So the best way to do that, it's hard to manipulate the potassium level in a live animal, just like it is in you. So the better way to do that is to take the muscle out, put it in a dish, it'll stay alive for several hours, and we can directly stimulate the muscle and record its ability to generate force. So this is the muscle force on a very fast time frame. We apply a series of shocks over about half a second. You can see the nice, strong contraction of this muscle from the hind limb of the mouse. Now, in this mouse susceptible to hypo-PP, if we lower the potassium in the bath from 4.7 to 2, as may happen in some of you during an attack, there's a tremendous decrease in the force that doesn't happen in a normal mouse. So we've clearly recapitulated the disease. And if you were to study a whole series of different potassium challenges, ranging anywhere from, in this case, 1 millimolar, which you all have never had because it's not compatible with life, but we can test it in the dish, all the way up to 10, you see normal mice in the open symbols, they tolerate that pretty well. Yeah, they get a little stressed out at the very low potassium, and you have about a 30% reduction in force. But you see the tremendous reduction in peak force for this mouse model of hypokalemic periodic paralysis that happens in low potassium, but not high. So again, recapitulating the key feature of the disease. The different symbols here are because we can actually breed these mice to have 2 copies of the mutation, a homozygote animal, which hasn't ever occurred in humans, but those mice are viable, they're just more susceptible to potassium. One additional piece of background information, and then we'll talk about our efforts at testing new therapeutic interventions. And that's to understand what's going on during an attack of weakness. So just to remind you here, the muscle sends a brief signal. It crosses a special synapse, the neuromuscular junction. And in response to that, this is electrical response, voltage versus time. On a very fast time scale, the muscle fiber itself has this brief transient called an action potential. It's about 1/10 of a volt, and that's the signal that tells the muscle cell it's time to contract. And that signal has to spread over the entire length of the muscle, causes calcium to be released from internal stores, and then there's a generation of force after a short delay. So that's the normal process. So what goes on during an attack of periodic paralysis, and what's interesting is that the mechanism I'm about to show in these final steps occurs for all the different variants of periodic paralysis: hyperkalemic, hypokalemic, Anderson-to-Will, and thyrotoxic periodic paralysis, for all of them. So what happens is, instead of having a system that's all set and ready to go to have this brief electrical transient, the action potential in the skeletal muscle, that what's happened is the battery has sort of run down, which means you're not as far away from 0 millivolts. So instead of being negative by about 1/10 of a volt, you're negative by about only 0.05 volts. And what that does is the system is then refractory. It cannot generate one of these spikes. For the anesthesiologists in the room, Bill, it's just like depolarized neuromuscular blockade. So this is permanently refractory with no action potential. There's no spreading signal to contract. That's your attack of weakness. So it's a functional disruption of electrical excitability that might last tens of minutes to hours. Eventually, your body, through potassium levels and other things, resets, and the starting voltage comes back down, and you recover. So that's what's going on back and forth. So a lot of what we've been doing to try to develop new therapies is think about all the different ways we can try to make your resting state of the muscle, have those batteries charged, ready to go, so you can send the signal and initiate contraction. So again, don't want to get too technical here, but the way we do this, we think of an individual muscle cell, which is a big long cylinder, as this fiber here. And we know from many decades of research all the key players to allow this battery to be charged and for the muscle to send this electrical signal. So there's some pumps and some transporters and a lot of channels, and they're moving salts in and out: sodium, potassium, chloride, all the things you've been thinking about. And it's the movement of these salts, which carry little charges, which enables the battery to get set. So I'm going to start out by talking about hypokalemic periodic paralysis. So in that case, there's a mutation that could either be in a sodium channel or a calcium channel, and it makes a leaky channel. So your battery runs down because the system is leaky. So just looking at that, you'd say, well, let's plug the leak, right? That's all you need to do. Well, that's not so easy, but we've been working for a long time to do that. So first let me make you aware of the fact that this is a common mechanism for all the different mutations that cause hypokalemic periodic paralysis, regardless of whether it's in the calcium channel, of which there are about 10 identified, or in the sodium channel, of which there are about 15. So all but one are mutations at a very special type of amino acid. It's a special type of missense mutation at an arginine in the voltage sensor. What that means is we're dealing with a common mechanism that causes the leak. So if you fix the leak for one mutation, it might work for many. Wouldn't that be terrific? What it also means is when you do genetic testing and you screen the calcium channel gene or the sodium channel gene, and you're looking for the possibility of hypo-PP, we know exactly what kind of variant you should see. And if you don't see that, it's a benign variant, and it's not what's causing hypo-PP. So this is how we've been able to help individuals interpret genetic testing. So the challenge we have here is the leak is in this little side chamber. It's where the voltage sensing part of the channel is. So instead of this big central pore, which is how sodium or calcium normally gets through, it's on this little side port. And that's a real challenge because there's wonderful history of developing lots of pharmacology and drugs that act on ion channels. So a lot of anti-epileptic drugs, antihypertensive drugs, drugs for mood disorders all act on ion channels, and many of them block the pore. But none of that pharmacology is going to help us because that's not where the leak is. It's next door. So we have to start from ground zero. And thinking about this, there's a related channel, I won't go into the detail, where some of our colleagues at the University of California in Irvine identified some small organic compounds that would get wedged into here and could potentially block this leakage current. And so we tested it in our genetically engineered mouse model of hypokalemic periodic paralysis. So let me help you through this. What we're doing is measuring the contractility of the muscle from this mouse in the setting of challenging the system with low potassium. So this is a long experiment, a little over an hour here. So every 2 minutes, we shock this muscle and say, contract, 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 show us how good you are. Starts out at 100%, it's very stable. If you take this hypo-PP muscle and challenge it by reducing the potassium to 2, it loses half of its force and then recovers when you wash out the low potassium. Conversely, for a normal wild-type mouse, that's the green symbols up above, you see how they tolerate 2 millimolar potassium. So again, primary periodic paralysis is not just because your potassium is low, it's because when your potassium is low, you have a mutation that makes you susceptible to other badness. So that's the difference here. This drug that's a pretty good blocker is the symbols in blue. So you see we preserved about 3/4 of the force even in the setting of low potassium. So that looks promising, but we think we can do better. The challenge is we need little molecules that can fit in this leak even better. And in the sodium and calcium channels that cause periodic paralysis, we don't yet have a tremendous atomic level structure in which we can look at that. So one of our graduate students now is modeling the sodium channel. All these ribbons are these amino acid string of pearls that make up the big pore sitting in the membrane. The thing I want to impress upon you is to build a model like this, little ball and stick model of all the atoms in an ion channel. That's 300,000 atoms, 300,000 little things you have to keep track of. So to model that, you need to use a supercomputer. So we lobbied for and got time on the CPU of the Anton 3 supercomputer at the University of Pittsburgh, and we're now getting a better picture of exactly where the leak is. And so what we're going to be able to do now is use computer simulation and other techniques to do the screening to look for good blocking molecules that would be way too laborious to actually test one after another in the muscle model. So an accelerated way to identifying new blocking drugs. And so that's where we are now. And hopefully I'll come back in 2 years and tell you all the wonderful targets we identified. So that's one way. Let's block the leak. There's another way. There's more than one way to skin the cat, right? So here are all the players in the muscle. I told you the problem is the battery runs down. You can't keep this thing charged. There's an electrical problem. Well, instead of focusing on the mutant channel itself, we have a lot of opportunities to modify other channels, other players that are bringing ions in and out of the muscle and then can therefore be used to stabilize the battery, that is the resting potential. And the one that will help us the most is if we could open some potassium channels so that the fiber is more permeable to potassium. What that will do is help keep the battery charged. Because here's our example of when everything's working well and you're asymptomatic. During an attack, zero's up here, so you're closer to zero. Your battery's partially discharged. And when you open a potassium channel, that's this little red line here, it tends to make this voltage come down to the red line. So prevent things from running away and depolarizing. So we went to our mouse model, and this time, instead of measuring force, we measured the voltage, the tendency of the voltage to change. Do you get this inappropriate positive shift in low potassium? So when we take now and we've poked our muscle with an electrode, and again over a long time period here over an hour, we're just passively looking at how well is the battery charged. So again, well charged means far away from zero. Your battery's charged, you give the low potassium challenge, and the battery's running down. This wouldn't happen in your unaffected family members. This only happens in muscle that's susceptible to hypo-PP. Low potassium, your battery runs down. Okay, we can go back to normal potassium, it recovers. Now we put in one of these drugs, retigabine, that promotes the opening of a specific type of potassium channel. You do the same low potassium challenge and the battery stays charged. So we've prevented the rundown of the battery by opening a potassium channel. Well, what does that do for the force? That's what you care about. Am I going to feel better? My muscle's going to work better. So we tested this same medication. Again, retigabine was developed as a first-in-class anti-epileptic drug to help keep neurons down at the resting potential of their battery, keep them from firing too fast for use in epilepsy. So this is the same thing all over again. Once every 2 minutes, we're looking at this mouse muscle and seeing how well it contracts. Here it is at baseline, low potassium, big, huge attack of periodic paralysis. But if you pre-treat with a reasonable concentration, low level of retigabine, it completely protects the muscle. What's even more important is if you start an attack, so this is looking at two different muscles from the left and the right hind limb. On one side, we don't give any drug, and it has a big attack and then recovers when you bring the potassium back. But in the other muscle, we let the attack get started, so you become symptomatic, and then add the drug, and you see the recovery. So the reason why that is really important is it shows this type of approach could be used as an abortive therapy. So you wouldn't have to take this all the time to prevent an attack, but if one starts, then you could take this and it would tremendously accelerate the recovery. So we've looked at the sensitivity of the system, how much protection do you get as a function of the concentration of the drug, and the bottom line is it's low, around 1 micromolar, so this is something that's completely achievable by oral administration of the drug. Well, this sounds all great, Steve, can you write me a prescription? Well, the problem is retigabine was taken off the market in 2017. So it had this propensity, it has all these big cyclic structures that come together and then absorb blue light and cause the skin and the eyes, the whites of the eyes to discolor and become blue. And GlaxoSmithKline got a little nervous about that, was worried about vision loss, although it never happened, and they took it off the market. Fortunately, the pharmaceutical industry recognized that this general concept of having drugs that could open potassium channels and help keep these batteries charged and quiet down electrically excitable cells would have many potential uses, and that they should keep looking. And so they were derivatives of retigabine, and one of the leaders in this has been Xenon Pharmaceuticals. And so there's been a trial for XEN 1101, which is, again, one of these potassium channel openers that they have used in epilepsy trials. It's now already gone to phase 2B. The safety has been fine. It's been pretty darn good as an anti-epileptic adjuvant as well in partial seizures. But what we care about is now there's a drug that's about to come to market that's in the same class. Is it going to work in periodic paralysis? So here's the raw data, again, looking at time and muscle force. Here's a raw contraction in one of our sodium channel mice with hypokalemic periodic paralysis. In 4 millimolar potassium, nice big strong contraction. We decrease the potassium and there's a tremendous decrease in force. This is an attack of hypo-PP. You put the drug on, this drug that's going to come out and be on the market completely protects from the loss of force in periodic paralysis there. So we've tested this rigorously in our sodium channel mutant mouse that has hypo-PP and the calcium channel mutant mouse. So again, whenever we challenge these mice with low levels of potassium, turns out the sodium one has this spontaneous oscillations, but clearly there's a loss of force. But in the red symbols, if you pre-treat with this drug, XEN 1101, you prevent the loss of force in either form of hypo-PP. For those of you in the room with hyper-PP, this is one of the two most common causes of hyperkalemic periodic paralysis. It's a mutation in the sodium channel. And so now we challenge the system with high potassium instead of low potassium. There's a pretty dramatic loss of force, and there's about 50% protection. So I would say there's room for optimism, but my prediction ahead of time, and again, this all needs to be translated over into well-controlled human trials, but the optimism there is there might even be some benefit for patients with hyperkalemic periodic paralysis. The science sort of makes sense that it should help as well. The other thing we've tested in this hypo-PP mouse, the one that spontaneously oscillates, again, we test the two muscles from the same mouse at the same time. In one tissue bath, we put no drug, and it just oscillates back and forth with these attacks and partial recovery and back and forth. And then while the attack is ongoing, if we add the drug, there's complete rescue. So just like retigabine, This drug can rescue from an attack as well, so you might not have to take it all the time. And I know you can't remember the numbers from the other graph, but basically what this is showing, this is the dose response. How much protection do you get versus how much drug? And this is actually 3 times more potent. So this is even more potent than vertigabine was. So completely achievable with oral administration. So again, before running out to your neurologist and asking for off-label use and trying to get a hold of some of this, again, it's pretty safe medication. I'm hoping some of our clinical colleagues out there in the neuromuscular space will work with us. It's a little outside my shop to organize a clinical trial and help establish with confidence that these medications will be of value to you. Now, in the remaining half hour, 20 minutes, let's say, let me talk about gene therapy. So that's the other place. This is a clearly inherited so-called monogenic disease, which means a mutation of one gene is enough to cause the full clinical syndrome. And so why not just go right to the source and fix the problem? And as you all know from probably reading in the press about other diseases, this is a big deal to establish these technologies, and sometimes the safety is quite challenging. And I will also say that delivery of these gene therapy molecular tools to skeletal muscle is a lot more challenging technically than to other tissues in the body. So some things to do. And so when you look at this and some of those hurdles, you might ask yourself, well, why would you do this? I mean, we all know, and you've educated me about the impairment of quality of life that comes with episodic attacks. Unpredictable attacks ruin, unexplained absences from work, you can't go to school, a big event you were planning gets wrecked. I get it. It's a problem, and there's pain associated with it. But the other thing, and we've seen this, you saw this beautifully in Karen Sutherland's talk this morning, it's just shown a different way, is the so-called burden of disease, the weakness over your lifespan. So you start with these very dramatic, brief attacks, usually around late childhood or puberty, and as you approach middle age, they tend to calm down a little bit. They're not quite as severe, but the duration tends to get a little bit longer. But then the major concern is that instead of these episodic attacks, there's now this slow progressive development of proximal weakness, usually especially of the legs, difficulty getting out of the chair, climbing stairs, and things like that. This, as you heard this morning, is a very challenging condition to study because the progression is so slow, it comes on so late. If you had a great idea, and we don't have mechanistic ideas of how to approach this yet. We don't understand the biology of what's going on. We can see the damage in the muscle under the microscope. They're big holes, these vacuoles, it's all torn up. But how those come and how those were related to the intermittent attacks, we still don't understand. So I applaud Dr. Sutherland, and now that she has a mouse model that shows some of these features, and the time is compressed on a mouse model, so maybe you can do it there and look for this. But for affected individuals, gene therapy is going to be the way to go, right? So if you eliminate the risk of the disease, you should eliminate the risk of late onset permanent weakness. So that's the incentive to want to pursue gene therapy in periodic paralysis. So it turns out there are several different flavors and approaches toward gene therapy. You could replace a gene, you could knock out a gene, you could go in and edit a gene and change a few things. So in periodic paralysis, these are dominant disorders, which means you get 2 copies of the gene, one from mom, one from dad. If one of them alone is defective, that's sufficient to cause the syndrome, okay, to cause periodic paralysis. Fortunately, we know from cohort data in genetic studies in humans as well as animal models that you can get by just fine with one normal copy of the sodium channel gene or the calcium channel gene. So what that means is if we could use gene therapy to destroy the defective copy, you'd only have one good copy, but that should be enough for everything to work. So one approach, the way to cut and destroy things, that's CRISPR technology that you've learned about. So CRISPR is just a molecular tool to have a very precise way to direct where your scissors go and make a cut in the DNA. But the key thing that you have to establish first is the little tool you need to make to tell the scissors where to cut. and that's not trivial. So what we did first is we isolated muscle from our mouse models, and we used the CRISPR technologies to say, could we develop a system that would cut the bad copy of the DNA, but not the good copy of the DNA? And that's not trivial because it differs by a single nucleotide. And the little reading pattern that you use to decide where to make a cut, it's scanning about 20. So you've got one change in 20 that has to be able to distinguish where's the normal one and where's the abnormal one so that we only cut up the abnormal one. And again, I know you can't read the details here, but this is how you look at genetic sequence data. As you go along here, you're running along the DNA, and each one of these humps in a different color is a different part of the genetic code. And basically what this is showing is that with this technology, we didn't make any accidental cuts in the normal copy of the gene. But in the abnormal copy of the gene, we disrupted about 60% of it. Not all of it, but it gets disrupted so the sequencing gets all scrambled, and that's what this histogram is showing, that we've cut half of it. Okay, so that's a pretty good first step. What we've shown in the dish is that we can make really precise scissors that are going to destroy the abnormal one but not the normal. Now you want to know, what's it going to do in the animal? Is it going to be enough to help prevent periodic paralysis? And there's a little shortcut we can take in the study of skeletal muscle that's not so easy in other tissues, which is that we can locally inject these little tools, it's little pieces of DNA, that code for these tools to make the cut, the scissors, into the foot, and by applying a little electric shock, it'll take up that DNA. So if you do that, then 2 weeks later, you can look at the foot pad. This is under a bright light. These are the toes of the mouse foot. And we put a little marker in there just to confirm that we successfully got our molecular tools into this mouse. And the marker shows up green under fluorescent light. So yeah, we got a lot of green in there. So our tools are there. What happens? Well, now instead of looking at muscle cells in a dish, this is looking at how effective was our editing? How well did those scissors work in a live mouse? And again, it cut about half of the copies of the bad copy of the gene and didn't affect the wild type at all. Okay, that looks good. So now we go to the more important question. Is this editing enough to make a difference in the behavior of the muscle, and have you done anything to the susceptibility to periodic paralysis? So again, now we're showing the raw traces force. We're testing the muscle outside the body of the mouse, apply a burst of electrical shocks and cause a rise in force. And what we're doing is comparing the two muscles on opposite limbs of the same mouse. On one side, we gave the gene therapy. On the other, we didn't. So right away, the one that got the gene therapy, the baseline force is a little higher. So that looks good, even in normal potassium. But more impressively, when we lower the potassium, the force is largely sustained in the one that had the gene editing, but not on the side that was a sham, that didn't. So it's looking like functionally we have an important difference. And if you look over many mice, here's the baseline amount of force you should get in normal potassium. In this mouse model of hypo-PP from the R528H mutation in the calcium channel, you can see there's already about a 50% lower force at baseline. But for those that had the gene editing, it's much better at baseline. But what's even more impressive is in red, here's the average response for all of the control side where we didn't do the gene editing, and you get your attack of periodic paralysis. And I'm showing all the individual responses from 5 different mice we did the gene therapy, and every single one had essentially cured their susceptibility to periodic paralysis from this. So we are really excited about this. And just to show you where we are in the big picture, because we have 3 different mice, so we will test this in 3 different ways. So what we've done, we have 2 different mouse models of hypo-PP, a sodium channel and calcium channel, and one for hyper-PP. In all of those, we've tested our molecular scissors in culture, and they work. They cut the bad copy, they don't cut the good copy. And we've also verified that the ability to edit the gene in the mouse works. It gets rid of about half of the mutant copies, and it doesn't do anything to the wild copy. I just showed you in the last slide, there's a tremendous improvement in force and loss of susceptibility to periodic paralysis in the calcium channel mouse We're doing this one next week and this one a little bit later, so it's still in progress. The big step here is that all of this proof of principle, which is really exciting, is locally only in the foot. So we inject the DNA locally, we do a trick to get those muscle cells to take it up. We haven't delivered the CRISPR tools to the whole body and all the muscles to the body. So a common way to do that in humans as well as animals is to use viruses. So viruses, they are little Trojan horses that bring foreign DNA to a cell. So people would use the adeno-associated virus to package all of our different molecular parts of the machine to make the precise cut, and then inject it into a mouse, and every single muscle will hopefully then be affected and modified, and we can test that. So we'll be making the viral particles next spring and seeing if that works. But once we get to that stage, then we'll be looking for industry partners and others to take it. It's way beyond the scope of one university laboratory to translate that to human trials. But if we are able to get that data, people will be off to the races. So I have one last slide, and then we'll have time for plenty of questions. That I've focused a lot today on hypo-PP. I was glad to see the show of hands that there's other representation of other channelopathies here. I want to say for Anderson-Tawil, we just had a big paper come out. It's a little bit complicated this year, but we made a mouse model of Anderson-Tawil syndrome, just the muscle part, not the heart part. And we looked at the really perplexing question of, do attacks of weakness in Anderson-Tawil syndrome come with low K or with high K? Because if you look, the first patients that were described, all of them had attacks triggered by high K, and you give them high K. And then later, it's been more consistent that low potassium was bad. And this is important because cardiologists who want to keep the rhythm safe and not have arrhythmia and sudden cardiac death, they want your potassium to be in the high normal range. That's safer from the arrhythmia standpoint. And what we were able to show is that this confusion that's out there in the literature, in the clinical neurology literature about describing ATS is exactly correct. That the potassium channel mutation, the KCNJ2, the KR2.1 potassium channel, when it is defective, the muscle becomes susceptible to either high or low K, both of them. So that's the only form of periodic paralysis where that happens. So that was a really interesting proof of principle, and just a word of caution as you think about adjusting your potassium for those of you with Anderson-Tawil syndrome. So the other slide, this is my final slide, is I haven't spoken very much, just a little about hyperkalemic periodic paralysis. Just in the XEN 1101 study to show it helps a little bit in hyper-PP. So hyper-PP is not one of these strange leaky channels, which is what hypo-PP is, but the normal behavior of the sodium channel is run a little bit amok because it doesn't completely shut off and it lets out too much sodium. So one of my longtime scientific colleagues at Columbia University, Manu Benjani, has been working on the problem of sodium channels that don't completely shut off. Because this is a cause of epilepsy, cardiac arrhythmia, myotonia, and periodic paralysis. So he's really good at protein engineering and designed a little peptide, little piece of amino acid, that would help completely shut off the final little bits of the sodium conductance. And it works in the dish, and he tested it on a long QT syndrome, and it worked there. And we're starting to collaborate, and so we're going to test this in our hyper-PP mouse to see if there's yet another approach that we can have to mitigate the problems and thereby have a new treatment option for periodic paralysis. So I just want to end by acknowledging the people who do all the hard work. Fen Wu is our expert molecular biologist and designed all the CRISPR tools. Marbella and Victor and Sharon did all those force measurements. Marino does all the complex electrophysiological measurements. And Gaurav just joined us and is doing the modeling on the supercomputer. So thanks for inviting me. I hope I can tell you even more in 2 years. So thank you.
All right, thank you, Dr. Cannon. I'm going to take some of the most upvoted questions in the chat. Are there any new research updates regarding treatments to treat the pain aspects of periodic paralysis?
Yeah, so pain, that's a really interesting feature, and I'm going to speak a little bit about that tomorrow morning. But what I have just learned, working with some collaborators in Finland, is there's certain sodium channel mutations that cause myotonia and pain, and the pain is the key feature, even without the myotonia, and it's really complex, and others here are working on that. And so it's an area that's gaining traction because it didn't get the attention that it deserved from the beginning, but labs are starting to go in that direction.
Very good, and more tomorrow.
Yep.
Is there going to be any new genetic research for variants that are either VUS or not discovered yet?
Yeah, so one of the frustrations is when genetic testing doesn't reveal the basis for somebody's symptoms and maybe in several family members. And I'm going to discuss that a little bit tomorrow. But what I will say is the punchline is for periodic paralysis, typical periodic paralysis, the three big players, the SCN4A, the CACNA1S, the calcium channel, and the KCNJ2, those three genes are the big players still, and for the foreseeable future likely will be for periodic paralysis. But I'll talk about the conundrum of what if you get variants that no one has seen before? What if there aren't even any variants detected? So I'll talk about that tomorrow.
All right, more stay tuned. Okay, number next, are there any known factors that increase the likelihood of progressive muscle weakness?
Yeah, so the short answer is no, and the whole biology of this progressive muscle weakness is really a mystery. Because, for example, as you heard this morning from Dr. Sutherland, that big family in the Netherlands, many of the women in that family, the little stars that she pointed out, they didn't have brief episodic attacks, and yet they developed the permanent weakness late in life. So there's a dissociation between the frequency and severity of attacks and progressive weakness that we don't completely understand. But I still want to put the important message out there that to maintain good muscle health, you should always try to minimize the frequency and severity of these attacks. We just can't connect the dots yet. And because we don't know the biology, we really don't have anything to grasp onto for trials, except for gene therapy. Because the idea is if you get rid of the root cause, then even if you don't understand where it came from, you get rid of the risk factor, would be the approach.
Very good. I got a couple more, and if there's some in the room, yep, there's one in the room at least. All right. For those of us with clear clinical syndromes that improve on medications like Keveyis and also have many affected family members, but for whom whole exome sequencing found no known mutation, do you have any thoughts as to where the mutations might be? Why are they not even VUSs found? In my case, the diagnosis is paramyotonia congenita.
Yeah. So the key part of that story is many similarly affected members of the family, because that gives you a toehold to do genetic analysis across multiple members, and the tools are getting better and better to sift through that. Because as you'll see, you don't have to, you can sleep in tomorrow. I'm telling you all the things I'm going to tell you tomorrow morning. When they discovered one of these rare genes through whole exome sequencing, that individual had 51,000 variants, which is what most of you are harboring. So to sift through those, you need a strategy, or it's hopeless. Yeah. So I think the interesting thing is in many cases, the behavior of the channel is modified. It's not that it's just missing or didn't turn on. And so because of that, I think other undiscovered genes and little pieces of the puzzle are going to have to be other proteins and things that directly physically interact with these channels. It's a big complex of players because that's the only way that's going to happen. But if they occur, they're very rare, but we'll keep looking.
It's my turn. Okay. Do you know if there's like any, what would be the word? Equipment where you can check your potassium at home?
Sure. So clearly there is a strong correlation between potassium levels and susceptibility to weakness in hypo-PP and hyper-PP. That's where the names came from. And historically, this was the first biomarker that neurologists had. But all of you know that It's not a perfect one-to-one correlation. Sure, if your hypo-PP and your K is 3.2, that is low, you're much more likely to have an attack, but you might not have one. And you might have one when your potassium is 4. So what you need to recognize is that the potassium level is really important, and it's kind of setting the stage, but it's not deterministic. There's still a lot of variability. So first of all, that's one limitation of measuring potassium. The second is, you all know it's frustrating in the emergency room to have the potassium measured from your blood, because it's not the same as the tissue potassium, and there's a big change in time, and it's the local potassium around the outside of the muscle cell that's going to be really important. So I know that, because I read the social media, that a lot of people are interested in testing the saliva with these potassium meters. My concern is, I really question the correlation between what your salivary potassium level is and your blood. Now, there are many people who say, I went to the emergency room, I had my blood tested, I did the saliva test, and they matched. Maybe, but to me, that's just another step removed from the potassium in the local muscle environment that I would be concerned. I mean, it might give a general indication. I certainly wouldn't trust saliva potassium to answer the question, is it safe for me to take additional potassium? You cannot use it for that at all. Okay, it's not going to be accurate enough, but it might give some indication. I think what may happen someday, and maybe we can advocate to have this type of device, but you all know there's those glucose monitors now you can wear and see it on your iPhone. I did it for fun because I'm a nerd, and it was really interesting to see what exercise does to your glucose levels. You could develop an electrode that was sensitive to potassium. That's what you need. It's going to be an indwelling, you wear it for 2 weeks, and it's right there on your iPhone. I would love to see that for periodic paralysis.
Okay, we had a couple of questions about new medications, and I think you covered that well. Don't you agree? Or do you have something else to say?
I think there's one paper that went out there and was distributed that talked about GLP-1 agonists and how that might relate to permanent muscle weakness, and I'm going to dive into the details of that tomorrow morning.
Very good. And then the CRISPR gene editing, I think we did cover, right?
Yeah,
in terms of what we can expect in the next 10 plus years. So I'm going to hand this to you.
Yes, I did. Thank you. Hi. Is it known which variants are susceptible to permanent muscle weakness, or is it only certain ones, or all of ours are?
Great question. That was one of the first correlations that we began looking for when the mutations were identified. And you probably know the count now is quite high. So even though it's about 10 or 12 for the calcium channel for hypo-PP, for hyper-PP and paramyotonia and myotonia, it's over 70 in the sodium channel. So it's many, many mutations. The bottom line is, for all three of the major forms of primary periodic paralysis, hyper-PP, hypo-PP, and Anderson-Tawil, all of them are at risk of permanent muscle weakness. Some neuromuscular specialists feel that if you look carefully enough, that nearly 80% of individuals will eventually develop detectable permanent muscle weakness by age 65. So it's out there. But if you look at earlier onset and severe and who begins to need assist devices, there's a little bit, not huge, but a little bit acceleration of this process for those with the calcium channel mutations in hypo-PP. But there aren't any get out of jail free point mutations that give you periodic paralysis, but not the risk for late onset permanent muscle weakness. It's been found for all of them. So.
All right, another online question. We've got a couple too. See you over there. I did the free Xeris testing and it didn't show anything, but my mom started having episodes in her early 20s like me, and hers continued until her 50s, then stopped. Now she has permanent muscle weakness. Since I'm second generation with these symptoms, I do think it's genetic. Is there more in-depth testing that we could do that might show something? What would you recommend we do next?
No. So unless you can work with a genetic counseling service and someone who wants to, in a professional way sift through this, it's a huge haystack. At the University of California and some other campuses, there's the Rare Disease Network, and I've actually worked with a family from this group, And we're doing just that because there are multiple generations that are convincingly affected and yet nothing has shown up. So those investigations are all kind of on a research level now. I'm not aware of a commercial opportunity to do that yet, but it's a rapidly evolving field, so maybe someday it'll come out.
The follow-up that comes to my mind, and probably a million other people, it's, are you accepting new folks? Should they just call you? I mean, I imagine not, right?
Yeah. So when I moved to California 11 years ago, I made the decision to focus on my laboratory and recruiting and training of faculty. So you are my clinical practice, okay? So I really enjoy having this contact, and actually I get a much richer understanding of how periodic paralysis impacts people by speaking with you all. What I do participate in is the Ask the Experts on the PPA network, and I'm very happy to answer those questions. And I probably get an email at least once a week from either Ask the Experts or someone from the healthcare system trying to figure out a variant of unknown significance, and I'm happy to do that. And so I provided some advice, but I didn't even renew my license in California, so I don't do e-visits or telehealth or anything. I apologize for that. But if you have confusing genetic results and you and your physician and your team are trying to figure out what it is, work through the PPA, or you can find my email on the University of California website, and I'll try to help you with it.
That's extraordinarily generous. Thank you. And a question here.
So I'm hyper, but we've had it in the family for years. We can go back generations. At the same time, my daughter was diagnosed when she was maybe 13, so 12, with this muscle disease. But at the same time, she was diagnosed with type 1 diabetes. So, of course, I was trying to treat her for my disease and giving her Dr. Pepper and Snickers bars and blowing her blood sugar out. But is there any, or was that just a freak thing?
Yeah, so that is probably a chance occurrence, but I will say it's a challenge to be an insulin-dependent diabetic and have hypo-PP, because when you take fast-acting insulin, your glucose is going to move into cells and potassium is going to move in with it. So work with your endocrinologist and try to have longer, slower-acting insulin and avoid the fast-acting, and just be aware that there's a risk for a dip in your potassium right at the time of insulin administration.
You said hypo, did you mean hyper?
No, hypo. Are you hyper?
No, she's hyper.
Oh, I'm sorry, I didn't hear you correct. So hyper, so maybe she'll get a little boost when she takes her insulin then. So that's, but you're right, and I was wondering about giving all those Dr. Peppers to hypo, which would be bad. So you're doing the right thing. Congratulations. Yeah, so it is a challenge. There are other ways that might be alternatives, potassium wasting diuretics, loop diuretics like Lasix and so forth, that again, it's something you would want to work carefully with an endocrinologist and maybe even a nephrologist if you want to avoid high carbohydrate diet. The other thing is, again, working with your endocrinologist, it's a matter of balance, right? I mean, if someone is really going down in a severe attack, to eat a candy bar once every couple of weeks, I think it's a better trade-off, even if you are an insulin-dependent diabetic, right? So, yeah.
So my question's about the muscle weakness as you age. So what would that look like as we turn 65, 70? Is that like, is it going to be like having to use a walker earlier than most, or?
Yeah. So the biology of muscle and aging is a really interesting topic, because all of us, after about age 50, even if you take supplements and exercise, you all have a decline in contractility and muscle performance. And so a really interesting question is that since that's happening in everybody, you have people with underlying neuromuscular conditions that are just hanging on by the edge. And this same process that's going on in everybody now causes you to have, problems with activities of daily living and so forth. So that might be part of it that's coming together in the age dependency. Although if you do serial biopsies in the same individual with periodic paralysis, the prevalence of those vacuoles and the muscle changes tend to get greater with age. So that's an issue. But by and large, my impression is that it's the muscles, the axial muscles of remaining upright and the proximal muscles of the legs, so particularly standing up out of a chair without using your arms or walking upstairs are the most commonly affected. I know there, you know, in medicine there's always exceptions to everything, but it's generally those muscles, and so walking is the big issue, and nobody wants to lose ambulation, right? That's a big change. But what's fortunate is I'm not aware, I know there are exceptions, but for the large majority of patients with periodic paralysis, function in the arms and the hands and swallowing and talking and breathing is relatively preserved. So I'm not aware of anyone who's had to have ventilatory support in old age with weakness that came from periodic paralysis, for example, or no longer able to eat by mouth or things like that. So fortunately, all those things seem to be spared. It's primarily the proximal muscles in the legs, walking, climbing stairs, things like that.
Over here, in your very last slide, you had a.
Sorry, it's hard. I get no. Oh, okay.
Sorry, over here. On your very last slide, you talked about the hyperkalemic synthetic peptide elixir, I think you called it, and the research toward that. Could you talk a little bit about where that sits in the research process? Is that something that's nearing any type of trial situation, or is that?
Yeah, so that is such a fresh fish. The paper hasn't even been published yet. So it's coming out this month. But so what it was, a proof of principle, a very insightful specialist in ion channels recognized that for many channelopathies, affecting many tissues, brain, heart, skeletal muscle, there was this common problem that the sodium channels don't completely inactivate at the end like they should. And we know what parts of the molecule are doing that. And so, again, doing a little bit of protein engineering and peptide design, it was like, hey, I think we could do something about that. And so that has just started. What was really interesting about that paper is that all sodium channels do this inactivation, so it's conserved across all the different flavors. And you have 9 different sodium channel genes in humans. So different ones in the brain, different one in the heart and skeletal muscle. And what they showed in that paper is that this little elixir peptide, they named it, that they developed, helped with the completeness of inactivation in all the different flavors of sodium channels, which is great. So it's a generalizable principle. They tested it for a cardiac condition in the mice. We're going to test it in the muscle. If that works, to get to your point, a new biologic, a peptide, which you can, sometimes you can even do tricks to make them bioavailable orally or so forth, would be a shorter path than something like gene therapy. It's less of a, so it could be a faster track.
Okay, I think we're going to do one more, and then we're going to wrap it up for today. But thanks for going extra innings with us. Did you have a question? Oh, he's pointing out. Okay. Well, let me ask you this. This came up from our thing, and I think we've talked about it behind the scenes. A lot of research funding seems to be up in the air at the moment. Obviously, this group really wants your research to continue with no hiccups. Can you tell us if your funding has been impacted? If so, how can we help?
So that's actually a big story. So you know that the federal government has exerted leverage on a lot of universities and suspended their grants. So on July 31st, they suspended 310 NIH grants at UCLA, including both of mine. $772,000 in research support stopped. So the university, as all universities have done, have looked for alternative ways to keep the machine going. And what has happened, I can say all this because it's in the public domain. This is still a very sensitive topic for all universities because the final outcome has not been legally determined yet. But a federal judge did file a preliminary injunction which put a pause to that, and a week ago our grants got reinstated. But the problem is this is a preliminary injunction and the hearing isn't until April. So we don't know what's going to happen in April. So there's been a lot of disruptions to biomedical research. and it hit home. But I will say to the point, though, they're dealing with that, of course, at the whole University of California system. And again, they have experts there, and it's a huge problem. But what I want to say, and with this support here, is thank everyone, because with support from the PPA, from some individuals, from the company and Jake's family, from Stronger Bridge before, from all of you, we started some exploratory studies, including all that gene therapy. I had never done gene therapy before. I'm an electrophysiologist. I studied channels. And it's really hard to write one of these competitive grants, even if you have a good idea, and say, hey, I think this is a good case for gene therapy. And they'll say, yeah, sure, but do you know how to do it? So the challenge is you need some startup money to get the preliminary data so that you can write a compelling application. Your money is what helped us get into the gene therapy field. So I really appreciate the question. I promise you that 100% of anything that comes in goes to the lab and nowhere else. And we'll try to make good on your investments. So it could either partially be organized through the PPA. My laboratory website has a donate here, and you click and it will take it right to me and not into just the general UCLA bucket. But again, we deeply appreciate, and we're very engaged in talking with anybody with special resources or representatives to Congress to help us with this, because it ain't cheap to do this, but I think we're making real progress, and we don't want to see this disrupted. So thank you.